Welcome to this Step 2 Clinical Knowledge Review on End-of-Life Care Test-Taking Strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for end-of-life care and teach you strategies to pick the right answer quickly and confidently. This includes goals of care discussions, withdrawal of life support, hospice and palliative care, and brain death determination. Remember, the goal here is not to reteach the entire topic, but to help you recognize patterns and apply test-taking strategies. Make sure you have reviewed the ethics and palliative care sections of first aid and your question bank before or alongside this video. Here is what we are going to cover in this video. First, we will learn how to recognize high-yield question stems for end-of-life care topics on board exams. Second, we will apply test-taking strategies for goals of care discussions, withdrawal of life support, and hospice eligibility questions. Third, we will master the next best step question format for brain death determination and palliative care management. Before we start, make sure you have your foundational resources ready. Review first aid and your question bank for the ethics and palliative care chapters. This video is about strategy, not memorization. Let us start with strategy 1, recognizing goals of care question stems. When should you think about initiating a goals of care discussion? Look for a patient with a new serious diagnosis, a progressive terminal illness, or repeated hospitalizations. The boards want you to recognize when the next best step is a conversation about goals rather than more aggressive treatment. Now, what does the right answer look like? The correct answer almost always involves asking the patient about their values, preferences, and understanding of their illness. Wrong answers typically jump to a specific intervention without discussing goals first. If the STEM describes a seriously ill patient, and the choices include a goals of care discussion, that is usually the correct answer. Strategy 2 is about withdrawal of life support patterns. First, who makes the decision? The patient's own wishes always come first. If the patient lacks capacity, look for an advance directive or a healthcare proxy. If neither exists, the next of kin or surrogate decision-maker decides. The boards test whether you know this hierarchy and apply substituted judgment, not what you think is best. Now for the key board concepts. When the question involves disagreement between family members, the correct answer is usually a family meeting or ethics committee consultation. An important fact to remember is that withdrawing life support is ethically and legally equivalent to withholding it. Providing comfort medications during withdrawal is always appropriate and is never considered euthanasia. Now let us talk about high-yield STEM recognition for 3 major topics. First, the goals of care STEM. Look for an elderly patient with advanced disease, multiple hospitalizations, and declining functional status. The question will ask for the most appropriate next step, and the answer involves discussing prognosis and preferences with the patient. Second, the brain death STEM. Look for a patient on a ventilator with no brainstem reflexes, no respiratory drive on apnea testing, and a known irreversible cause of coma. The question tests whether you know the clinical criteria and the legal definition of death. Third, the hospice referral STEM. Look for a patient with a terminal illness and a life expectancy of 6 months or less who is no longer pursuing curative treatment. Hospice focuses on comfort, not cure. This distinction is heavily tested. Here is our first practice question. A 72-year-old woman with metastatic pancreatic cancer is admitted for the 3rd time in 2 months with intractable pain and progressive weight loss. She has full decision-making capacity. Her oncologist recommends another round of chemotherapy. The patient tells you she is tired of being in the hospital. What is the most appropriate next step in management? Your choices are A, refer to hospice immediately. B, schedule another round of chemotherapy. C, conduct a goals of care discussion. Or D, consult the ethics committee. Take a moment and think about what pattern you are seeing here before we walk through the answer. Let us walk through this answer step by step. Step 1, spot the pattern. Advanced cancer, repeated admissions, declining functional status, and the patient expressing she is tired of being hospitalized. This is a classic goals of care setup. The patient has capacity and is signaling she may not want aggressive treatment. Step 2, apply the rule. Before making any major treatment decision for a seriously ill patient, the next best step is always a goals of care discussion. You must understand what the patient wants before proceeding. Step 3, eliminate wrong answers. Choice A, referring to hospice, skips the conversation about what the patient actually wants. Choice B, scheduling more chemotherapy, ignores her expressed wishes. Choice D, an ethics committee, is for unresolved disputes, not initial conversations. The answer is C, conduct a goals of care discussion. Here is our second practice question. A 45-year-old man suffered a massive intracranial hemorrhage 3 days ago. He is on a ventilator. He has no pupillary response, no corneal reflex, no gag reflex, no cough reflex, and no motor response to painful stimulation. An apnea test shows no respiratory effort despite adequate carbon dioxide rise. What is the most appropriate next step? Your choices are A, obtain a confirmatory electroencephalogram, B, declare brain death and notify the family, C, repeat the neurologic examination in 24 hours, or D, discontinue the ventilator immediately. Think about what the clinical criteria are telling you here. Let us walk through this brain death question. Read the question carefully. This patient has an irreversible cause of coma, absent brainstem reflexes, and no respiratory drive on apnea testing. These 3 criteria together define brain death. No confirmatory test is required when the clinical examination is complete and unequivocal. So why do you declare death at this point? An electroencephalogram is a confirmatory test that is only needed when the clinical exam cannot be completed. Repeating the exam in 24 hours delays the determination unnecessarily. Discontinuing the ventilator without declaring death first is incorrect because the legal declaration must come before discontinuation. The answer is B, declare brain death and notify the family. Now let us cover a critical distinction for the boards, hospice versus palliative care. First, palliative care basics. Palliative care can be offered at any stage of a serious illness alongside curative treatment. It focuses on symptom management, quality of life, and support for both the patient and the family. The boards test that palliative care does not require a terminal prognosis and is not the same as hospice. Now, hospice care basics. Hospice is for patients with a life expectancy of 6 months or less who have chosen to forgo curative treatment. It provides comfort-focused care, including pain management, emotional support, and spiritual care. The boards frequently test the 6-month prognosis requirement and the choice to stop curative interventions. Know this distinction cold for exam day. Here is our third practice question. An 84-year-old man with end-stage heart failure has a left ventricular ejection fraction of 15%. He has had 3 hospitalizations in the past 6 months for decompensated heart failure despite optimal medical therapy. He tells you he no longer wants to be hospitalized and prefers to be comfortable at home. What is the most appropriate next step? Your choices are A, refer to hospice, B, refer to palliative care, C, increase his diuretic dose, or D, refer for cardiac transplant evaluation. Think about what this patient is telling you and whether he meets criteria for hospice. Let us walk through this hospice question. Spot the classic pattern. End-stage heart failure, very low ejection fraction, repeated hospitalizations despite optimal medical therapy, and the patient expressing a preference for comfort over aggressive care. This patient meets criteria for hospice, meaning a prognosis of 6 months or less and a desire to stop curative treatment. Now know the key distinction. Palliative care alone does not address this patient's expressed wish to stop hospitalizations and stay home. Increasing diuretics continues aggressive management against the patient's wishes. Cardiac transplant evaluation is inappropriate given his age and stated goals. The answer is A, refer to hospice. Here is an important test-taking pearl about comfort at end of life. When life support is withdrawn, the priority is managing the patient's pain, difficulty breathing, and agitation. Opioids and benzodiazepines are appropriate to ensure comfort. The principle of double effect states that providing medications to relieve suffering is ethical, even if they may hasten death, as long as the intent is to relieve suffering and not to cause death. The boards test whether you understand that withdrawing and withholding treatment are ethically equivalent, that comfort medications during withdrawal are never euthanasia, and that the intent of the physician determines the ethical permissibility. These principles appear repeatedly in ethics and end-of-life questions on the exam. That wraps up our review of end-of-life care test-taking strategies for Step 2. To keep studying, review the ethics, palliative care, and end-of-life chapters in first aid and your question bank. Focus on goals of care discussions, brain death criteria, hospice eligibility, and the principle of double effect. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you with your board preparation and match strategy. If you found this video helpful, please like and subscribe for more board review content. Good luck on your exam.